back. And are you able to see the MRI, Sonny?
Yes, sir.
All right. And you can see the white arrow is on the L45 disc, which is damaged and doesn't look normal. That one and the one below, the L5S1, which the arrow is on now. And the patient's pain is coming from a small area in the back of the disc, not the front, not the sides, the back, as is always the case with a painful disc. And the reason is there's a tear back there, and some of the jelly from the center of the disc has squeezed out through the tear in the wall of the disc. All right, Dr. Deuk here, we're going to get started. Are you comfortable? Dr. Deuk here, we're going to get started. Are you comfortable? All right. Just lay still. If you feel any pain, say ouch, and then tell me if it's in your back or your leg, down your leg, okay? So say ouch back or ouch leg. You're going to feel a little stick while I give you some numbing medicine, okay? So just, everything's okay. Yeah, that's normal, don't worry. So, this patient has had back pain for a while. How long have you had back pain for? I'm sorry, that's just a numbing medicine. It burns and hurts a little bit. I apologize. So how many years have you had back pain? Well, I don't want to say his age, so just how many years do you think? Just give me a rough estimate. 17 years, roughly 17 years of back pain. And one of the things I talked to him about is the discoloration of his skin down here is unusual, and it's because he's using basically ice packs to treat his pain for such a long time that it's actually changed the color of the skin. Pretty remarkable. Huh? That's... There's lidocaine, right? It's odd. We hope, right? So our patient has had back pain now in his lower back for almost 18 years, 17, 18 years, and he's not been able to get rid of it, basically, which is why he's now here at Deuk Spine. He wants to cure it, and we're able to do that for him with this surgery. I'm just giving you more numbing medicine, okay? We're good. We're good. We're good. Yeah, we're good. All right. We just gave you some more numbing medicine. Seems like he's very anxious. Do you have any anxiolysis going on? All right. Very good. Well, was that a while ago? No, just relax. Lay still. You're fine. All right. Yeah. This is more of a... How's the blood pressure? It looks good. Wow. Yeah, he's got a lot of soft tissue discomfort, which is not really normal, but probably related to the skin changes. Yeah. So with every patient, you get a different experience. Everyone perceives pain differently. It can be the same source of pain, it can be the same type of pain, but how your brain perceives pain at the cortical level is important, and there's differences. So pain is actually what we call in the neurosciences a cortical experience, meaning that it's what you perceive on the surface of the brain or cortex. All right, let me know when I can proceed. Our patient has a nice body habitus. Is not a large person, so it makes it a little bit easier for us. All right, what we're looking at on the X-ray here, lateral view. Jordan's, nice job. You've got the L5S1 and the L45 disc lined up. And I'm just giving another minute for the medicine to work. But Yeah, we got a high iliac crest. Huh? You're doing great. Everything's going perfect. Yeah. Yep. You're fine, I promise. Sure. Just relax. Try not to move. You just say ouch, and that's all we need to know, okay? You're doing great. All right. One more lateral. All right. You're okay. Let's go, AP. Now, he took his morning pain medicines, right? All right, and that's the AP. Where's the lateral? That's the lateral. We got another centimeter. So we probably need to be a little bit more medial. What can we do? Is the IV working?
Yeah, it's working.
All right, let's go back to a lateral, please. Huh? Oh, this is not pain. This is perception of pain. This is cortical. This is a anxiolytic solution rather than a fentanyl solution. You're fine, I promise. Everything's going well. Your soft tissues are just very sensitive for some reason. And that's okay. All right. We've given him plenty of local pain medication. Shot? You're doing fine, I promise. Shot? Yeah, whatever you feel comfortable doing. I mean, he may be right on the edge. He may be right on the fence where, you know, he needs just a little more. But safety is number one, so whatever you're comfortable with. Huh? Shot? Yeah, of course, I do too. You're doing fine, I promise. Nothing's wrong, it's just uncomfortable. All right, let's get one more. Good. Let's go with an AP. You're doing great. We're almost done. So, you know, I've done about 1,300 of these surgeries, and one thing that I've noticed is everybody responds a little bit differently. So we're about a centimeter away. A little bit more than a centimeter there. Where do you feel the discomfort? You feel it in your back or your leg? Sean? All right. All right, let's go back to a lateral. So, one of the issues we're dealing with is something called polypharmacy. And, you know, people who are in pain for 17 years, they take all kinds of, you know, drugs, basically, medications to try to get out of pain. And it makes it a little more challenging for me to do what I have to do, but Sean, my job is to work through that and to fix his back problem, which I can do once we get down to the disc. Sean, which we're close to. Sean? All right, let's get an AP. Let's see where we are. You're fine. So what we typically do is have our patients take their usual medications that they take. All right, that looks pretty good. Let's go back to a lateral. And that way, you know, they're more controlled, because patients, by the time they get to us with 17 years of pain, they know what they need to get comfortable. So we encourage them to take their regular medications. Sean? I need to be I need to be a little bit more medial than I am. You're fine. You're fine. You're doing really good, I promise. Shot. Yeah, shot. You're doing great. Just lay still. All right, shot. AP. We want to make sure everything is perfect, so your surgery is great and you don't have any issues and you're very happy with the results. You're doing fine. Just lay still. Take a few deep breaths. That's where we are. All right, let's go back to a lateral. Now, what I can tell you is, you know, his anatomy, he has very, compared to a lot of people, his pedicles are narrower, so his posterior elements and facet joints are more medial. Shot. You're doing really good. Just hang in there. We're almost done. Shot. And I just feel like I'm too lateral on the disc. So let's go back to an AP and let's see where we are. We're using an X-ray machine to navigate and to get to where we need to go. And Jordan's done a great job of lining things up on that lateral view. One thing that he does have short pedicles at L5, abnormally short. That looks good on the AP. Let's go back to the lateral view. Because his pedicles are short at L5, he has a narrow foramen at L5S1. I'm happy with our positioning on AP, but I'm not happy with our positioning on lateral. So I want to redo this one more time. Yeah, you're fine, I promise. Nothing bad is happening. Shot. You're doing really good. Shot. And this poor patient has had so much inflammation. Yeah, we know. You're fine though, I promise. Now I'm feeling the facet. Shot. Yeah, you're doing a really good job. Shot. All right, AP, that looks better. It feels better. Let's get an AP, verify, and then we'll go back to a lateral, and we'll be done with this disc, and we'll move up to the next one. Yeah, it looks good. Let's go back to a lateral. You're doing good. What do you think his response will be to the discogram? Right? Almost done with this one. Shot. He has a huge tear. I could feel it. You did good. That was your bottom disc we just accessed. We'll make a little incision now. Is there no? I mean, where do we get this stuff from? I know, but it's supposed to be numb. I mean, I'm infiltrating quite well. You can see I'm raising a wheel and everything. I'm going to do a little deeper too while I got you. Move your hand. Oh yeah, I'm not worried. I'm just want to make sure it's working. Just giving you some numbing medicine, that's all. I've done a total of about 8 mil. All right, just take a few deep breaths. You're doing great. We're going to put you to sleep soon. All right? Just another 5 minutes and we're going to put you to sleep, I promise. All right. Poor guy. This is unfortunately what happens, folks, when you let back pain keep going for a long time. And, you know, you're fine, I promise. And you treat it with what's called polypharmacy, which is just basically medications, rather than fixing it. And it literally changes your psychological makeup of the person to where they don't tolerate. You're fine. Try to relax. Try to relax. All right, we're pretty close here. Shot, AP. I'm right on that facet. Almost done, I promise. Just take a few deep breaths and relax. So obviously the patient is tightening up. It makes it a bit harder to do what I need to do. Lateral. You know, his paraspinous muscles are tightening up. You're fine. We're almost done. This poor guy. All right. Are you able to help him settle down a little bit?
No, so that was 4 verses.
Shot? Yeah. You're fine? Yeah, we're nowhere near his nerve root, so. I've never seen anyone. You're fine. And never seen anyone respond this way. Because we're not even near the spine. We're literally in the soft tissues. Shot? Okay, you're doing good. Just lay still. But what I could tell you is, if you let things get, you know, go on for years, shot, not addressing it properly, unfortunately, this is one of the potential outcomes. Shot? Yeah, you're doing good. We're almost done, I promise. We're right there. Shot? All right, AP. So when we get the picture, we get a nice crisp for a second, and then it disappears to a blurry. That's because of movement. You're fine. And we don't take the insults personally. Shot. All right. Lateral view. So we're just in the foramen on the lateral border of the disc at this point. All right. Just take a few deep breaths. Try not to move. Okay. So we've confirmed we're at L45 and L5S1. Just relax, Shot. All right. All right, let's get comfortable. Yeah, we're going to take a break for a minute. Take a few deep breaths. You're doing great. Where's his blood pressure? Okay. So for those of you who have watched these surgeries over the years, we have patients who literally just lay still and don't make a sound. We have on the other side, unfortunately, situations where because of the way the pain's been managed for so many years, there's a different type of response to just the most basic things, like putting a needle in. And I feel horrible for the patient to feel this way, but we're not creating much pain at all, honestly. We're just putting a needle in. But it's how he responds to pain. And I don't think it's not familial. Is he comfortable? Are you comfy? All right, we're going to get you cleaned up with your nose. Why do we not have a tissue? You have suction over there? You can suck? All right. Let me know when you're ready. All right, so basically we've made one incision. It's 7 millimeters. It's tiny. The amount of pain we've created is minimal. However, the response is dramatic. And again, that has to do with the perception by the brain surface, called the cortex, of what the patient's experiencing and how they respond to it. A lot of it is psychological, and it can be improved with not necessarily biofeedback, but obviously with certain types of medications we can give to settle the brain down and reduce anxiety. All right, don't move. You're doing fine. Are you comfortable? All right. All right, well, there's one herniation. You okay? I know, we're shot. Having trouble getting, he's got a lot of scar tissue in that disc, that's probably why. Let's get AP. All right. I think we can go ahead and put him to sleep. Let's have the stylus. We're going to put you to sleep, okay? Just lay still. No, just... Just has a lot of secretions. Yeah, I know. But runny nose and everything. Yeah. Is he, let me know when he's going to be asleep. Take your time. Yep, take your time and let me know. I won't do anything more until he's asleep. I'm going to put the guide wire in at least, just to...
Yes, please.
So, how is he doing? Oh, he's asleep. So I can proceed? So, on a scale of 1 to 10, in terms of getting our patient, getting access to the disc with the needles and getting up to the discogram point, this was about a 10 in terms of difficulty for the patient. Though we didn't create any more pain than we do for the other 1,000 of these surgeries I've done, it was his perception of the pain that was really the most difficult thing for him and us, because his perception of the pain is severe, and that perception again is something that happens on the surface of the brain that relies on what's called association cortexes and very complex circuits of neurotransmitters in what's called the sensory association cortex. And the sensory association cortex are the parts of the brain surface adjacent to, abutting and connected to the primary somatosensory cortex. And they receive inputs from things like the limbic system, which controls emotions. And so when you have, 17 years of pain, it has an effect on the limbic system, which is the emotional system of the brain. And it can actually cause a rewiring of circuits. And it could cause upregulation or downregulation of neurotransmitters, and basically what we're seeing here is an example of that. This patient's perception of his pain is dramatic, but I think part of it is the chronicity of the pain, how long he's had it, but also, unfortunately, some of the medications he's used to deal with it. Is that it right there? And those medications aren't really helping him in a good way, He's incredibly sensitive, hypersensitive to the pain stimulus. Shot? Let's see. Shot. Let's get an AP. So, the beginning of the surgery was very difficult for him. And we've tried to make it as comfortable as possible, but when you have what's called an unsecured airway, which is what he has, an unsecured airway. All right, let's get a lateral. When you have an airway that it doesn't have a tube in it, or an LMA, to control the breathing, basically when you do twilight sedation like we're doing, you don't want to over sedate a patient, because then you could end up in a situation where they stop breathing or they obstruct their airway, and we don't want that. So it's a delicate balance between, it's got to be the biggest tear I think I've ever seen. And the pressure in this disc is just pushing the dilator out. Shot. It's literally pushed the tube backwards. That's incredible. Let's just go and take a look, see what we got. We may have to reposition. Let's see what we got. Yeah. Move the scope out, please. There's so much pressure in his disc that it's literally pushing my instrument out. Sometimes you have to, yeah, it's right there. So let's see if he pushed it out or not, or if we're still there. The pressure in the disc comes from usually inflammation. Inflammation creates swelling, and the disc is a confined space, so it has a wall. So when there's swelling and pressure, you're going to end up, yeah. No, it pushed it out. That's amazing. So we got to redo it. Scope off. Let's just keep him comfortable. Let's get the scope back in. The fluoroscope, that is. Needle. So now that he's asleep, I'm going to attempt to access the foramen with him asleep. It's going to make it a little bit easier for me. Let's put pressure here. No, get a rolled towel like you always do. Don't change what you do. Go ahead. We need a lateral view, my friend, not an AP. Why are you not putting in a lateral view? All right, so we're just going to wait a minute, and I have to re-access the disc because the pressure inside the disc is so massive that it literally pushed my instruments out. You can see on the lateral view there's a herniation there. You can all see that ball. I'm just going to wait a minute. Why is the fluoro shifting? Okay. All right, get us a good lateral view, please. There's way too much white in the back there, Jordan. I shouldn't have to tell you that. You should already know that. Yeah, that is correct. That's better. I think that's a little too much. I would come down a little bit. All right, so we're getting everything set up. I'm going to have to re-access that L5S1 disc. It honestly should be a bit easier now with him asleep because he was moving around so much, creating so much movement of the bones, contraction of the muscles. He has a lot of pain here in the soft tissues. I don't know if it's related to his skin burns that he has from the years of using the ice. He said ice packs cause this. So I've never seen that much discoloration from ice packs or heat packs, but ice and heat pack chronic use can definitely change the skin. All right, just give another minute. I don't feel any intramuscular hematoma, which is good. Everything is supple. Just give it another minute. We still have discogram juice if we need it. Yep. All right. So we're just holding pressure on the paraspinous muscles for a few minutes because we had the tube in. We don't want any bleeding. So the only bleeding you're going to get is venous bleeding, veins, and venous bleeding is at 12 millimeters of mercury pressure. Okay, that's the pressure in the venous system of the body on average, 12 millimeters of mercury. So all you need to do is 12 or 13 or plus millimeters of mercury pressure on the veins wall, which is pushing on the muscle, transmits that pressure to the wall of the vein, and then you stop the venous bleeding. Arteries have whatever the systolic blood pressure is, 110, which is what it is, over 60. So arteries fluctuate between 110 to 60, but the smaller ones don't have quite that much systolic pressure, because by the time the blood gets down to the arteries down here, the pressure is not the same as that in the arm where we're measuring it. And it's going to be a more constant type of pressure rather than up and down, up and down. Oh, boy. Okay? You okay over there? All right. Shot. Any questions from our audience so far? Shot?
Nothing yet.
So, a lot of scar tissue around here. A little higher than I want to be. You okay over there? Shot? 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 AP? All right, so we're right at the disc. You all right? I can actually feel the disc right here, Shot. And again, it's a little too medial. I mean, a little bit too far in. So I'm going to try again. Let me have the knife. Now that we have him comfortably asleep. I can actually take my time and take that. Just added another millimeter. Shot.
We have a question.
Go ahead, Sonny, with the question.
Is there a limit as to how long an injury could be and
How
still be
long what?
fixed? Is there a limit to how long an injury could be and still be fixed?
No, there's no limit to how long an injury can exist before it gets fixed. AP. However, having an injury that causes pain constantly, it changes a lot about a person. It changes a lot about their psychological makeup, for example, what we call the psychological makeup, which is really just the natural psychological response to pain and how it affects human behavior, normal human behavior. So, in essence, it changes your mood. It changes how you perceive everything in a day-to-day fashion. Shot? You know? It changes your personality. And it really has a tremendous toll on the person's on the person's, just how they live and perceive life every day. The joy, pleasure, all the typical emotions that people get. So you have that, okay, that factor, and that has nothing to do with getting rid of the pain that I'm doing today. It has everything to do with how you perceive life and pain, and then you add on top of that the fact that some people self-medicate, Sean, but also some people are given lots of drugs by their doctors. They prescribe all kinds of stuff, Sean. And so, AP, doctors are giving narcotics, then they're giving benzodiazepines, a totally different class of drugs that affects your anxiety levels or your stimulation levels. Then they give muscle relaxers, a totally different class of drugs. So the problem is that we're giving all these drugs to patients to treat their pain, and yet those drugs are having a negative effect on how people live life and how they perceive pain ultimately. Because those drugs are working on your brain by affecting what are called neurotransmitters, which are little chemicals in the brain, and altering the neurotransmitter pathways. AP? So, that's kind of what we're dealing with. We're dealing with the long-term effects of chronic pain on the brain and circuits and neurotransmitters and rewiring, and then you're dealing with the effects of medications that are prescribed to the patients for their pain and the effects of those medications have. Sean? I'm just not happy with this localization. But I am at the facet. Shot?
We have
Definitely
another
at the
question.
facet. Yeah, give me a second. I don't know if I answered that other one well, but that's the best I can do. So fixing the pain is not a problem. That's easy. That's what I do with surgery. That doesn't change. Yeah, the longer you wait, the more scar tissue there is, Shot. And the harder it is to fix. However, I can fix, Shot. I can fix people's damaged discs and get rid of the disc pain even 20 years later, 30 years later. And it doesn't get any harder. It's the same. However, what I can't fix is the chemical imbalance that their brains have as a result of chronic pain. You know, that I can't fix. That's where I am. And where's my lateral? There. Huh? All right, let me try again. I'm still not entirely happy with that, so I'm going to come a little bit more lateral. Lateral. What other question do you have, Sonny?
All right, we have from Bill. Do the annular disc tears always occur at the most posterior position? Otherwise, I'm wondering how the foramen approach is consistently reliable.
All right, so the question was, one more time, Sean?
Do the annular disc tear always occur at the most posterior position?
So does the annular disc tear always occur, Sean, at the most posterior position? The answer is no. Annular tears happen all around the disc. Sean? All around, front, back, and sides. But the only ones that cause pain are the ones in the back, like these. And that was a discovery that I made at Duke Spine Institute years ago, and it's still not as of yet known or discovered anywhere else. I'm the only person that knows that. I've published it, I've educated on it, but it hasn't, that knowledge hasn't caught on yet. As a matter of fact, most spine surgeons, if you ask them, hey, I got a herniated disc, is that causing my back pain? They'll tell you no, because they don't think it is. They don't know that a herniated disc can really cause back pain or neck pain. They'll tell you they're not going to do surgery for your herniated disc to get rid of your back pain or your neck pain, okay? They're going to tell you, we'll do your herniated disc surgery to get rid of your arm pain or your leg pain, but not your back pain or your neck pain. Shot? Let's go AP and see where we are. So the fact that a posterior in the back of the disc tear is the cause of the back pain, that's not something that's widely known yet. And it's something that very few doctors understand. Let's do reposition the one before as well. Because that's, he pushed it out. Incredible. But he has had a lot of Valsalva going on because of the pain he's had while we were doing this. So I'm actually happy he's asleep myself, but at the same time, normally we keep people awake for this part. I need a lateral. Because I need to know if I'm getting too close to the nerve root, and if I am, the patient will say, I got pain shooting down my leg, but I feel very comfortable, and I think having him awake is just hurting us in terms of getting the into the disc properly. Can you line up 4-5 properly, please? So having him asleep right now is actually going to make it safer for him, which is normally not that way. I need people normally awake to help me get into the disc properly. But because when he's awake, he's moving everywhere. As soon as I move the needle a millimeter, even when I'm not even close to the spine, I'm in the muscle or the fascia. So having him asleep right now, I think, is safer and better for him. Can you line up the end plates of 4-5? It may not be far off, and it may just be some of the residual dye from the discogram, but let's see if you can. I don't think that's too bad, actually. Let me try with that, okay? Shot. My hands are a little sticky, Luis. Wonder if you can help me. Just a little bit. That's good. So my hands are sticky because of the contrast that's inside the die. Shot? So what's amazing is right now I'm trying to access the L45 here, and he's not responding at all. And some of you may say, well, of course he's not responding because he's asleep, Shot. And you are partially correct. I wonder if we got an orbital thing, but let's just keep it for now. Yeah, he's asleep, so he's not having all that conscious response to the pain, Shot. But his body can still respond to pain if he's feeling it. And that's our reflex pathway, okay? Reflex meaning that he doesn't have a conscious control over it. But he's not. He's not having that pain, okay? And why isn't he having that pain? Because this part of the surgery really isn't that painful, to be quite honest with you. He was just having a really bad response to it because of his cortical makeup, his psychological makeup from all those years of pain and not treating it properly and having, polypharmacy on board. So it's quite amazing to see how now he doesn't have such a reflexive response to the pain at all. His muscles aren't contracting. He's not responding in any way at the spinal level. And reflexes happen at the spinal level, in case you're wondering. So he's not having even a reflexive response, which is a good sign. It really means that all that response he had earlier was truly mediated by his brain surface, which is now asleep. Shot? Let's go with an AP. I'm awfully close. I like how it looks on the lateral, but I want to check the AP view.
We've got another question, though.
Sure.
Can disc herniations cause sexual dysfunction?
Honestly, I couldn't hear what you said, Sonny. Can disc herniations cause something, but I couldn't...
Sexual dysfunction.
Oh, can disc herniations cause sexual dysfunction? The answer is yes, but probably not in the way that you're thinking. Like, most of these herniations don't cause sexual dysfunction directly, but the pain that people feel from the herniation can definitely cause sexual dysfunction. The mood change that people experience as a result of the herniation, like just being in a bad mood all the time, can definitely affect sexual function. Shot? And then, of course, the medications used to treat the pain, Shot, can definitely cause sexual dysfunction. So, AP? So basically, the medications are more likely to cause the sexual dysfunction, and then of course the pain can cause sexual dysfunction. But the actual compression of nerves, pressure on the nerves by the herniation is unlikely to do that. I mean, it can happen, but it's not common. I don't know why. Let's go back to a lateral. I don't know if you're just not lining it up properly. All right, that is a little bit clearer right there. It looks like he's got a little scoliosis going on here. So I'm going to have to come in at a slightly different angle. Shot. I can feel his fascia, Shot. That was what was bothering him a lot earlier, the dorsal fascia, and it's just very thick, which is not normal. Shot. It feels thicker than normal to me. Shot. Now normally Shot doesn't take this long to get in, but I have to be really careful because he's asleep. Shot. And I can't rely on him to help me. Shot. So AP, that to me looks better. than the last one. We're just wrapping around the facet. We're getting close to the back of the disc. I'm hoping that's what the AP shows. So AP shows I'm a little more lateral than I want to be. So I have to redirect again. Let's go back to a lateral view. You can kind of see the scoliosis, folks. The spinous processes are going up from L5 and L4, and then they're rotating off to the right side of your screen. So he does have a little bit of degenerative scoliosis, which we're not going to be fixing today, Shot. All right, let's try some orbital play and just see if that improves things. Just do a little orbit. Let's see if that helps me a little more. I don't think so. The other way. Shot. That is better. That is better. Yep, that's definitely better. Let's keep that. Maybe I'm not so far off then. Shot. That's where I'm feeling the disc right there, and that's what I'm seeing on that view. AP, so because he's rotated at this disc at 4 on 5, it's twisted the side I'm on away, basically from the level below, right side. So the vertebrae are not lined up properly right here. You can see what's called lateral listhesis with the vertebral body on the opposite side at 4-5. Basically, this right side that we're working on is twisted away from us by about 6 or 7 millimeters. And it's moved the left side of the spine away from us as well because it's a bone. So the whole thing has to move. Give me a second. Let me just think about this. I'm very close. Let's go back to a lateral view. The needle at 5-1 looks perfect, so I'm very happy about that one. I just want to get 4-5 perfect. Shot. I'm going to come a little bit more lateral. Shot. That's the facet. Did you have another question, Sonny? Shot.
No, not at the moment.
I'm really glad he's asleep because he would not be tolerating this much at all. He would not be happy with this. With every one of these passes, that looks better. See how the facets are offset just a little bit, the tips? It's because of the rotation of the spine. And I'm hitting his facet right now, which is what I want, and I want to just go right around it. And that tells me I'm in the right spot. Shot? So I don't know that we can do better than that. But shot. No. I'm still hitting his end plate up there. Yeah, even though his body is thin, his anatomy, deep anatomy is really challenging me right now. But I don't give up easily, and I really want this to go as good as it can for him. So, shot. It's a little bit too low, and shot. That's too high. Shot. Shot. That's looking better. Shot. Yeah, you know, this is interesting. This disc is really scarred up. That was all scar tissue. All scar tissue. Very, very thick. And it doesn't surprise me to have that much scar tissue in a disc that has been, you know, damaged, going on damage for so long. Of course, we're not going to get a response from him because he's asleep, but I feel really good about both of these localizations. And, you know, to be honest with you, it was difficult to do both of these for me, even with him not moving. So imagine how hard it was to get it right when he was moving. It was really hard. So I feel good now. I feel that we're safe and we can proceed. Let's just hope that disc doesn't push this out again. You have another question, Sonny? Sean? Can see
Yeah,
the
no,
tip of
not
the
at the
guide
moment.
wire. We're going to start with L5S1. So after a long beginning here, we're finally more or less underway in the standard treatments. You can see the guide wire there at 5-1 shot. And honestly, if he was awake right now, he would just not be able to tolerate this. And I feel that the fascia again it feels to me so thickened with inflammation. I don't know what he's had done, you know, in the last 17 years, but you know, the skin is atrophic and it feels scarred as well. So whatever treatments he's done on his skin has definitely had an impact below the skin, which is why he's, you know, responded with so much discomfort while we were gaining access earlier. Shot. Oh, I don't want to pull the guide wire forward, so I have to. Shot. Let me just make sure we're seated all the way in. Last time it got pushed out. Shot. It's feeling better this time. Just want to keep it anchored. Shot. All right, that looks good to me. Now, last time the pressure inside the disc literally pushed my tube out. So let's try this again. He's asleep and appears to be far more comfortable at this point. So we've gotten him deeper and he's stable, right? Shot. Yeah, so he's not fighting, you know, and compressing with his muscles. He's not pushing this stuff out. Shot. That looks good, right? Yeah, it looks good. Shot. All right, so we're deep there. We got it. We'll work our way out. I'm expecting at this point the surgery to go the typical way it does. Since he's so nicely controlled with his sleep, and I feel good, like we're in, and it hasn't pushed my tube out, so we should be okay. So the reason we air these surgeries live, number one, we can answer questions, but number two, you can see the challenges we face with each one. And not all of them are challenging to the same degree, but, you know, you get to see how spine surgery is a little different for different people. It's not always the same, laser. So the idea is going to be the same, but think about, you know, 2,000 years ago, people on the Silk Road, everybody knows what the Silk Road is. I'm not talking about the new Silk Road on the dark web, but the old Silk Road, where traders used to take things, products from one country to another along the Silk Road, trading. And, you know, even though the initial and final destinations were the same, every time they went on their route, the journey was not the same. There was different people on the road, there were different challenges. Maybe there was drought one year, there was no water, you know, at the watering hole. Maybe there were pirates one year trying to steal your products. the point is the journey was different each time. And the same thing in surgery. Even though the surgeon may have the same surgery, the same name of the surgery, the same levels treated, the same screws and rods, the same cage, those things remain the same. However, the anatomy of the patient and the bleeding during surgery and other things change the actual circumstances of the surgery and make it different each time, slightly different. Now, are those differences significant? Well, today they were. Even though this is a thin patient, normally you would expect an easier time getting to the disc, but his thinness and the fact that the pedicles were so narrow together and the fact that he was moving around a lot, because in the beginning when he was awake he was more uncomfortable because of his hypersensitivity of his skin and his low threshold of pain tolerance because of the way he's been perceiving pain and dealing with the pain with, you know, all the different treatments he's tried. All of that added together has created, like, you know, rolling 10 7-sided or 6-sided dice, okay? You roll them and, you know, 10 of them together and you're going to come up with a different combination every time. And that's what surgery is like. It's slightly different. You know that you still have 10 dice. You know that there's only 6 sides. And maybe the dice are colored, different colors. So you're going to get a different combination every time, okay? So you get a different outcome, a different number. For us, you know, we try to prepare as well as we can for the challenges that occur. And today we were prepared, as usual. It was challenging to get in, but we overcame the challenges. And eventually we're now proceeding with the disc repair as expected, you know. This part was also different for every different patient. Sometimes you get more scar tissue, sometimes you get less. We're deep inside the disc right now, and I can tell you we haven't encountered all the scar tissue we're going to encounter at this disc. It's going to get worse as I get closer to the surface. So that's my prediction. See, there's a big tear there. This all needs to be debrided. And this is a debridement of the annular tear. Do you have any other questions from our audience?
Yes. We have one question from Craig.
Huh?
Yes, we have one question from Craig.
Okay.
When will artificial disc be available for the lumbar spine, like the Mobi-C for cervical issues? I don't see much discussion around this area. Is it because of the load issues?
So, first of all, thank you for asking a question. Which platform was this question asked from?
YouTube.
YouTube. All right, great. So thanks for asking about the artificial disc in the lower back. And the question was, when will the artificial disc in the lumbar spine be available in the United States, I presume, but I don't know what country you're in. But let's presume it's the United States. The artificial discs are already available in the lumbar spine. And they've been available in the lumbar spine now for longer than actually the cervical. Since at least 2002. They started becoming available, I believe, somewhere around 2002, so almost 20 years. The problem is several-fold. Number one, would you want your belly slit open and all your intestines and organs moved over and pushed aside to get to the spine, and then, you know, have the risk of complications of going through your belly to implant an artificial disc? The answer is no. Going through the belly to get to the lumbar spine is very dangerous and entirely unnecessary unless you're putting an artificial disc in. So the only way to put an artificial disc in the lumbar spine is through the front, not through the back or not through the side. Eventually they'll have side-loading artificial discs, but we don't currently. So there are artificial discs for lumbar spine. They've been around in the United States, approved, FDA approved, and started implanting for at least 20 years now. The reason you don't hear a lot about them is they, honestly, in my opinion, they suck. And they fall out. They do pop out. and people have all kinds of complications from them. So I don't put artificial discs in. It's an older technology. It's far worse than what you're watching right now. This is a much safer surgery. And everybody that has an artificial disc could have this surgery instead. So I don't recommend putting metal in your body and putting an artificial disc over this type of surgery. That would be like the difference between sending in the Navy SEALs to kill Saddam Hussein in his house while he sleeps at night versus dropping a nuclear bomb on the area. The nuclear bomb is going to cause a lot more damage, and it's a lot less effective than selectively going in and extracting the problem. That's what this surgery does. We selectively extract the problem. The whole cause of back pain is coming from this tear that I'm cleaning right now. Now it may look big to you, but from side to side on this metal tube is literally 6.5 millimeters, okay? So basically, the inside of this tube is 6.5 millimeters. That's like almost a quarter of the size of a dime. It's, I mean, a half the size of the dime, a US dime. So this is a very, very small incision and a very, very safe and minimally invasive treatment. Now this patient could have had an artificial disc, okay, but he didn't want it. He wanted this laser surgery because it's less invasive, and the recovery time for this surgery is 1 hour. Literally 1 hour he could drive out of here. He'd be awake, alert, ready to go. But we can't let him drive because he just had anesthesia, so we wouldn't do that. But by tomorrow he'll be back to driving and doing things normal with a little bit of soreness in his back from the actual surgery incision itself, rather than an artificial disc, which is going to be a long recovery, painful, and of course those discs pop out. There was the problem with artificial discs, and one of the problems is that they're owned and developed and manufactured by companies that are in the business of making money by selling implants, whether they're screws, rods, or cages. These companies, they make all their money by selling screws and rods and cages and things that are unnatural and are put into your spine to stop pain. Okay? This surgery we're doing right now has nothing unnatural. It's a more advanced technology. There's no metal, there's no plastic, there's no cages. It's literally just repair this tear with the laser as you're watching. The blue thing, by the way, is the laser. And so the problem for those companies is there's no money for them to make on this surgery because we're not using a cage or a artificial disc or an implant. We're using reusable equipment, metal tubes and scopes. So their profits would drop dramatically if they started promoting the surgery. So basically, you have Dr. Deuk Majan at Duke Spine Institute talking about this amazing surgery, but you're not going to hear about it from other surgeons who are getting paid lots of money to do fusions and artificial discs, because they make a lot more money doing their surgery than I make doing this surgery. So there's no, the players in the game of spine care are not motivated to do what's best for the patients. They're motivated to do what's best for themselves. And unfortunately, that's the reality of spine. And that's why we do these broadcasts, so we can educate the public on the truth. And the truth is that spinal artificial discs and spinal fusions and any kind of metals or implants or biologics that go into your body for spine surgery, it makes a lot more money for the people involved than, say, something like this that we're not putting in things in your spine and leaving them in. So those companies are not motivated to get the word out about this surgery, even though it's better. That's what we're dealing with. So that's why we broadcast, so people can see the truth. You make up your own mind. You decide. Is the end result of this surgery better or worse than an artificial disc? I know the answer, the real answer, based on 26 years of being a neurosurgeon and doing spine surgery exclusively for bad discs, I know the answer. I know how to put artificial discs in. I was trained to do it 26 years ago, basically, or 24 years ago. We were one of the first institutions putting artificial discs in at Shands Hospital in Gainesville. We had a very strong relationship with the companies that were buying, the development companies who developed the artificial discs and took them through FDA trials, and of course started implanting them in humans. We were part of those trials. Our spine surgeons in Gainesville, Florida, at University of Florida, were part of them. We were the first to be putting stem cells into the spinal cords of spinal cord injured patients with Dr. Richard Fessler in Gainesville. So we had, we were a university. How's the irrigation? Good? We were a university hospital system, one of the top in the world in Gainesville for neurosurgery, and we were doing all of these artificial discs, stem cells, treatments 20 plus years ago, doing all the research and experiments on people for it, okay? So what I can tell you is that the reality is that those artificial discs don't work that well, and they're dangerous to put in, okay? But the companies that paid hundreds of millions of dollars for the technology, they don't want to just write that off. They want to promote those things and try to get more surgeons putting them in. But there's been a lot of resistance to it because, in my opinion, the data is not reliable. Okay? It's not reliable. It's been not altered, but biased with the outcome data. So yes, I know how to put artificial discs. I know how to do fusions. I know how to do laminectomies, discectomies, all those types of spine surgery. I've done many, many hundreds of them. But this is the surgery of the future because it's so amazing and minimally invasive, endoscopic, with the best results of all those surgeries in terms of patient-reported outcomes. You know, patient-reported outcomes are the most important outcomes. They are, they're what the patient reports, okay? So the patient-reported outcome is really about, all right, how much of your pain did we get rid of? You tell me. I can't tell you. You tell me. The patient reports that. And we get that pain reporting as a percent. How much of your original pain, the pain that you came here with, did we get rid of? And they give us numbers like 90%, 100%, 95%, but it all comes from the patient. And patients come here and they get surgery, whether it's artificial disc surgery or spinal fusion, it doesn't matter. They get surgery because they want to get rid of the pain. The problem is spine surgeons tell you we don't do the surgery for pain because they don't think it's going to work. They're not doing it for pain because they don't know how to, number one, figure out what is the cause of the pain, but number two, they don't know how to fix it. So do artificial discs get rid of back pain? They help back pain, but they don't cure it. Do fusions get rid of back pain? Most of the time they help back pain, but they don't cure it. This procedure has cured back pain in over 1,000 patients to date in the 16 years we've been doing it. And the back pain that this procedure cures is the back pain that comes from a herniated disc. Okay? Now there's other causes of back pain besides herniated discs, like the piriformis muscle, the sacroiliac joint, okay, the facet joints, and this surgery does not fix those back pains, okay? Just to be crystal clear. This surgery only fixes herniated disc, bulging disc, back pain. Yeah, we're getting a little red bleeding, and that's coming from the end plate. So we were working right up against the end plate of S1. And it may look kind of bad, but it's not, because it's very minimal, to be quite honest with you. Let's see here. Just about done. I just need to finish this. You have another question, Sonny? Sonny? Hey, Sonny? I missed that. Luis, you sent that scope out, right?
Both of them. I sent a cervical and lumbar. It's already. I ordered a repair, man. I'm sorry.
Oh my God, Luis, how dare you? How much is it?
It's 1400 each
Oh,
one.
Jesus, the price have gone up?
No, it's about the same, and it's the cheapest one.
My God.
Well, they are very good.
$1,400?
Yeah, they're very good. They do it good. They do good job.
They do it quickly?
Yes, sir. Yes, sir.
Do they stand behind their work?
Yeah. No. I mean, I'm still waiting. They're repairing right now. So
Uh-huh.
I sent it last week. And
But if there's a problem, when it comes back, they take care of it? Now, have you looked at the history on those scopes?
what do you mean, like,
Grab her.
if
Like-
they fixed before?
Yeah, if they fixed it before, was it just a month ago?
No.
Things like that.
That was we have been using there for no fixing before.
No
At least those
fixing
ones.
before. All right, let me have the laser.
Yes, sir.
Just about done at 5.1. I want to make sure we get everything. Don't want to bring him back. Those are great questions, by the way. Any more questions, honey? All right. For those of you who are not aware, Duke Spine Institute does have an app. It's free to download. We don't charge for it. It's an educational app. You can actually ask questions. You can look up spine conditions that are common, like herniated disc, radiculopathy, stenosis. And you can learn about the conditions and the treatments available. We are still working on the app in terms of evolving and developing the content, and we actually have released a new video that highlights why herniated discs cause pain. For those of you who don't know, go to our YouTube channel, Duke Spine YouTube channel, and check out the new video animation that was just created by Zach and our team. And we talk about how these herniations can actually cause back pain. And it's really through inflammation, in case you're wondering. And that's what we're treating here. We're getting rid of that inflammation.
Hey, Doc, I have a question.
Yeah, give me a second. And then the other thing you can do is, if you know someone, we're done here. If you know somebody who has back or neck pain or thoracic pain and they want to get rid of it, have them submit an MRI review. We do it for free. We don't charge. We do it whether or not you treat with us, to be honest with you. Whether you treat with us or not is inconsequential to whether we help you. We can at least make a diagnosis and give you advice. And those consultations are free. They're a telemedicine consultation. After you've submitted your MRI, you can actually sign up for a 15-minute telemedicine where we'll sit down and review your MRI, the findings, and how those findings relate to your pain or that person's pain and symptoms. Whether it's back pain, neck pain, arm pain, or numbness, tingling, weakness down the leg or in the arm, we will sit there and tell you why it's happening and what we recommend for you. So, and that's all free service from Duke Spine. We don't charge. We do that as a community service to help people that are in need, because the reality is there's probably over 125 million people in the world that are suffering with chronic back and neck pain, and they're not getting answers. And the truth is not out there. It's incredibly biased opinions. Of course, you could say mine is biased, but my opinions are born out of facts and success of treating people with chronic back and neck pain. So I tell you it as it is. If there was a better surgery to get rid of back pain than this, I would be doing it. I'm not limited in what I can do. I do the most advanced surgeries in the world. I do the most complex surgeries with screws and rods and cages. There is no surgery out there in the spine that I cannot do. We don't treat tumors and whatnot, but we do, just get a shot. We do, we treat degenerative conditions like herniated disc, spinal stenosis, things like that, okay? So it's not that I can't do other types of surgery, I can. And they actually do pay better. They pay me better. So it's not that I'm motivated to do this over them for some reason other than what's best for the patient. So the reality is this surgery is on every single point, whether it's recovery, whether it's pain relief, whether it's use of postoperative narcotic painkillers for the actual surgery pain itself. There is none in this surgery. People use Tylenol and Flexeril, a muscle relaxer, for just a day, and then the pain is from the surgery is gone. If you have open surgery like artificial disc surgery or fusion surgery, you're going to be on painkillers for weeks, if not months, after surgery. And those are narcotic painkillers, okay? We don't have anybody on narcotic painkillers after laser surgery. Now, some people come in on narcotic painkillers, okay, and they're taking narcotics because that's what they've been taking for years to treat their pain. We're not going to stop those narcotics the next day because they could go through withdrawal, so they have to taper off their narcotics. But this surgery gives them the ability to get off of the narcotics and get their life back, you know? Keep it a little bit. And up. All right, now pressure. What's the question?
Well, next time you're in the endoscopic view, they would like to know, where you're working.
Sure. Yeah, we didn't do our typical diagram today on the patient's back because, he was in so much pain. We had to really load him up with painkillers to get him comfortable and asleep to the point that I could actually operate and actually get the needle in, to be honest with you. And once again, that is, him and just his body and his physiology and his psychology that's unique to this patient. And everybody's different, by the way. Everyone's response to pain is different. But like I said earlier, for this particular patient, he's going to watch this surgery afterwards. We're giving him a copy. He's going to hear everything I've said. But I want him to know the truth. Shot. The truth is that he was really bad off. I mean, I really worry for this patient because he was in a bad way with the medications that he was on and is on, and then the other treatments he's doing for the pain and nothing working. I mean, I feel horrible for him. Let me see here. Shot. Just not happy with that kinking, but shot. Give me an AP. Fucking hell. No, I want an AP. A quick AP. That looks pretty good. Lateral. Problem is his spine is rotated away from me. Just give me a second to get in here and get this thing done. Shot. AP, no, give me a minute. What? No. Fucking hell. No, this is turning out to be a very complicated one. I need that needle again. Just put pressure for a few minutes. All right, we'll take the question. No, reload it. I'm not happy with that positioning.
No other questions at the moment.
What's that?
No more questions at the moment.
All right. All right. So I wasn't happy with the guide wire position with the dilator, and I'm going to reposition things one more time. Once again, his spine is rotated, and just to help you understand how it's rotated, these are the vertebrae. Normally they line up like this, but when you get scoliosis, one of the vertebrae rotates away from the other. So a little dramatization, the disc being here. So he's got one vertebrae rotated away from me, and that's the L4. And so when that happens, the facet joint is still here, but getting past the facet joint into the disc, you have to go further medial to the other side. And that's what I was struggling with earlier. And as I was going down to get in the disc with the dilator, that facet was pushing the dilator anterior or away from the back of the disc. So I decided to start over. We'll just put pressure for a few minutes. How's he doing? Yeah, his vitals look good. He's not moving. He's breathing beautifully. So the patient is safe and stable. It's just taking the surgeon a little longer than normal. But you get to see the challenges we have. I wasn't happy with the positioning of the tip of the dilator on that AP fluoro. Are you showing the AP fluoro?
I am now.
Yeah. So if you look at the tip, right below it is a circle. That circle is the pedicle of L5. And then if you go up above the dilator tip, just above it, about a finger's breadth up, is the pedicle of L4. And the position of the tip of the dilator relative to the pedicles is, I'm not happy about that. It's not entering into the disc through the tear. I can't feel it going through the tear. So I'm too far to the side. So I'm going to start again. And yeah, this surgery is ending up taking a lot longer than we expected it. But, you know, the reason for that is his anatomy and physiology, and I'm a bit of a perfectionist. I want it to be perfect. So I don't want to take any chances with him and not have a really good result. So I have to start over again. And that's fine. I don't mind starting over. Shot. All right. So I need a dock against the facet. Shot. That's too far up. Shot. 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 Now I feel shot the facet. There's the facet. I just want to slip around it. Shot. Shot. So yeah, the facet big, and it's actually pushing my needle. Shot. Lateral and anterior. Shot. Shot. Yeah, it's amazing. So the shot, I may have to make a second incision. Shot. Just to make sure. Shot. You can see the tear below, and that's what I'm really aiming for. Shot. 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 See, that's all facet forcing me north. Shot. And I'm trying to force myself south. Shot. Let's go with an AP, see where we are. It's actually pretty darn good. Lateral. You can actually see the arthritis on the facet right there. That bone. That's amazing. Alrighty. Shot. Shot. You know what? It's amazing. I'm gonna have to start higher. I'm pushing his skin up. What? Yeah. Pressure. Just to make this as good as it can be. So what's happening, it's quite interesting actually. The facet joint, I have to go around that facet joint. And normally you hit the facet joint, you can go around it, but he's got an extra bone growing there, so I'm hitting it and it's deflecting me and pushing me further to the side rather than going to the middle. That's what I'm dealing with. So I'm having to start from a different position and attack the disc from a different angle. So that's what I'm going to go ahead and do right now. Let's see if I can make this work. It doesn't lose us anything. He's just going to have 2 incisions, but I would rather him have 2 incisions than not get this disc done or not do it safely. Shot. I'm so glad he's asleep for this. Shot. Shot. And the scoliosis has a lot to do with this issue because the scoliosis is causing the facet joint to enlarge. Shot. And it's the enlargement of the facet joint that is, I can feel it. It's literally pushing the needle. Shot. Oh, we're right there. There's definitely a little bit of listhesis too. You can appreciate it better now. Shot. AP. That looks good. Lateral. You know, on the surface you think this will be a very like a slam dunk, but the anatomy is the challenge here, and pretty substantial challenge, but we're getting it. I feel the disc. That's amazing. Are you lined up? Let's do a little more wag, like a degree. I mean, I can't tell if the pedicle's lined up properly or not. Is it? Maybe the other way? Let's go 2 degrees the other way and see where we are. I mean, I'm hitting the end plate. And that's not where I really want to be. Let's get this lined up better, Jordan. I know there's dye in there. It makes it harder, but I don't think we're far off. Let me have the wag. All right. Shot. 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 Let's lock that in. I may just have to really be coming from quite a bit higher. Let me see the spine. Shot. 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 Try not to push the needle. During the shot. There's the facet. Shot. I like this trajectory better. But again, I'm hitting bone. Shot. Let's change the orbit a little bit, see if we can line it up a little better. Pick one way to go. Is that it? Is that the way you went? So hard to tell with the dye there, huh? Let's go the other way. I don't know, that seems worse. Try it again the other way. Yeah, I think that's better. So the shot, patient's scoliosis has quite literally caused the facet to enlarge here, which is what is obstructing shot, but I'm slipping right around it. It's obstructing, no pressure. Shot, my access to the disc is essentially what's happening. All right, AP. Let's see what we are here. That looks good. Shot. All right. Oh, we're definitely in the disc. Let me just discogram it just to make sure. Blood pressure good? Shot. No. Shot. Good. We're definitely in. I think we're safe. All right, let's see if we can't get this to work right. Shot. Got my guide wire in, taking out my needle. Shot. Let's just make sure the guide wire hasn't moved. Just a little bit forward is fine. So I had to literally attack this disc from a different angle to make it work. I need a knife. So we're going to have to do a second incision. I've never had to do that. Maybe one time only where I had to make a second incision. I'm just happy that he's asleep for this so he doesn't have to feel it. But it's really unusual to have to do 2 incisions for 2 discs that are next to each other. But that has a lot to do with the facets and his scoliosis and some listhesis going on at 4-5. And that's obviously out of my control. I can't do anything about that. Shot. But we have to adapt our technique and what we're doing. Shot. Otherwise, we'd have to abort doing this level or do something unsafe, which I don't want to do.
I got a question.
Sure.
How laser is better than using graspers and annular cutters for taking out fragments and cleaning the annular tear?
Well, laser is better because it's A, precise, but B, it cuts tissue, you know, this type of tissue better than grabbers do. For those of you who've watched me do these surgeries, the grabbers don't really work well. They only just pull out loose pieces of tissue, like pieces of herniation that are loose. So the only way to get those pieces of herniation to be loose is to free them up, free them off. They're stuck to the annular tear. That's the problem. And we need to unstick them. What that means is the annular tear, can you see this, Sonny?
Wait, the camera view?
My hand.
Yeah.
The annulus tears, the jelly pushes through. Do a jelly push through. Do a jelly push through. The jelly pushes through. Go ahead. Okay? And now the annulus is trying to heal because it wants to come back together. It knows it's torn and your body tries to heal, but the jelly is stuck there. So you put a grabber in there and it can't grab this stuff off because it's all stuck into the annular tear now. It's scarred in there from inflammation. So you try grabbing it, it doesn't come out. So the laser actually debrides the annular tear. And that does work. But grabbing it doesn't work. So regular surgical instruments don't work. Period. I've tried it, it doesn't work. The only way to get that annulus cleaned up is with a laser. There is one other way, but it doesn't work nearly as well. And it is the use of a bipolar or plasma. It's basically plasma energy as opposed to laser energy. So the dilator is moving, shot. It's amazing, the dilator is getting pushed out again. Do you see that? So plasma energy works, shot. Let's see if, okay. Thing of a McBob. I need to get that out. Yeah. So the laser energy is better than plasma energy in my experience, by far. Plasma energy is what a bipolar creates. There is a endoscopic bipolar available. It's from a company called Eloquis. And some endoscopic surgeons use it. It's long and very skinny. But in my opinion, it's not nearly as good as a laser. Not nearly as good. The laser is far better. Now the people who make the bipolar, of course they want you to use their product and so they can make money. They'll tell you it's good, but it's not. I don't make money selling lasers. I don't make money selling any of this stuff. So I'm just going to tell you the God's honest truth. The only way I make money is getting paid for doing the surgery. But I don't make money on any of these products. I'm not a vendor, salesperson, distributor. So I'm giving you my unbiased, experienced view. I've worked with the bipolar before, but the reality is in my opinion, it absolutely sucks compared to a laser. Like a laser on a scale of 1 to 10 is a 10. The bipolar is a 2. I mean, if I was using the bipolar, we wouldn't be able to air these surgeries because I'd be cussing all the time because it doesn't work. It's just a horrible tool. It's good for other things like coagulating blood vessels, but it's really bad for removing collagenized disc, scarred up disc herniation and annular tear. The laser is the tool. There's nothing in the world better. Not even close. There is no mechanical tool that works. Now you can see some of the herniated fragments come off easy and they float up, but most of them are stuck, like this right here. That blue thing I'm working on is a piece of nucleus pulposus stuck to the annulus. You see that? The laser is modulating the tissue. It's basically releasing the herniation off the annular tear right there. Hey, without the laser, you're not going to do it, period. So the laser is essential part of eliminating back and neck pain endoscopically. Otherwise, forget about it. It's not going to work. All right, this is all scar tissue from chronic inflammation. Remember, this patient's had pain for 17 years, so then 17 years is a lot of inflammation to go on in this little area right here. And it creates a massive amount of scar tissue. The golden color is calcium inside the scar tissue. So the white and gold there you're seeing is totally abnormal. It's not normally found in the disc. The only reason it's in his disc is he has a tear, and that tear has been inflamed, causing back pain, but also becoming scarred for 17 years, basically. Yep. By the way, the story it's an age-old story in terms of it's been going on since human beings have had discs and they've been loaded with weight. This has been the cause of back pain all these years. Okay? So, like any condition that affects an animal and causes disease or problems, it has a source. And that source of back pain at Deuk Spine Institute, we've discovered it as it pertains to herniated disc, and it's the annular tear in the back of the disc. We're literally the first people to publish that in a video format, and we just published it recently. You can get on to YouTube and go to the Deuk Spine Institute YouTube channel and see that video, and it explains how back pain is caused from an annular tear and followed by a herniation. The annular tear by itself will not cause back pain. You need a interposed nuclear herniation. Interposed means the part of the herniation stuck inside the annular tear. Okay? And the part of the herniation that's outside the annular tear actually doesn't cause much symptoms at all. It's the part that's wedged inside the annular tear that causes all the back pain and about 95% of the leg symptoms as well. All right. There's the tear right there. You can see it at 12 o'clock. And the blue thing is the laser. And this blue stuff here that I'm zapping is the stained, degenerated, herniated disc that's wedged inside the tear. The degenerated, interposed nucleus pulposus. That's what it is. And you cannot get rid of that with a grabber. You may be able to saw it down if you had a special agar drill or the agar drill. I think it's the agar drill. Basically a drill bit. But who wants to stick a drill bit down there and turn on to a drill? I wouldn't. Can't really see what you're doing. It's blind. The one thing surgeons don't like to do is surgery that they can't see. Ask any surgeon who wants to do blind surgery. You won't get too many hands raised for that one. I don't think anyone will raise their hand. When you can't see what you're doing in a person's body, it's a bad thing. So we use our eyes, direct visualization. We use rods and lenses and illumination and magnification basically. And we can use a fluoroscope. And the old days, this procedure called intradiscal electrothermoplasty, IDET, was popular back in the 90s. And a doctor would just stick a needle in the disc and then run this fiber down it and turn it on and just go zap, zap, zap for a minute, and it would create a little core. But it didn't work because you couldn't see what you're doing. You couldn't actually treat the tissue that needed to be treated. Okay? So notice what I'm treating. I'm treating the tissue that I want to treat. I'm guiding this tool, this laser, I'm moving it. The movement of that laser around this tube is not random. It is controlled by the surgeon, by me. I'm zapping pieces of this stuff that I want to zap. So I'm actually in control of modulation of tissue. So I am the one controlling what tissue gets zapped and what doesn't. And it's a three-dimensional entity that I'm working on here. This is not two-dimensional or one-dimensional. When you have a laser fiber that goes down a needle called the IDET procedure, which they don't really do anymore, by the way, that was a two-dimensional procedure. This is a three-dimensional procedure, okay? Like I'm trying to get that stuff right there, right now. So it's not haphazard. This is fully controlled by the surgeon and under direct visualization, okay? So I can see directly with my eyes what's happening here. And now I'm happy with this field. I'm going to pull my tube back, expose the tear a little more, and work on it, okay? It is pretty badly scarred up, by the way. So this patient, I think, is going to be very happy with the results, but he also has all this pain coming in his soft tissues, which I'm not treating. So will that go away in time? I don't know. He's done a lot of damage to his skin, you know, prior to coming here, unfortunately. And that's from years of living with this pain. And it's not his fault. I don't blame the patients ever. I blame the doctors for not knowing how to fix these people and not recommending treatment. Now, when a patient is confronted with an ability to cure their pain and they choose not to, now I can blame the patient. But when you tell people that there's no way to get rid of their back pain, that they just have to live with it, they should take these medications, pills, they should do shots, and none of those treatments are going to cure their pain, well then, now I blame the doctor because the doctor is misinforming the patient about their diagnosis and the proper treatment. But when the patient knows the diagnosis and the proper treatment, and they're offered that treatment, and they choose not to do it for whatever reason, then I would blame the patient, okay? Potentially, unless they have other reasons like financial, they can't afford to do it or whatever, okay? But still, it's a personal choice. But I can't blame people who really have been misinformed by those people that they trust for years because their doctor was not making the right diagnosis or offering the right treatment. I would never blame the patient. But when the patient knows the right answer and then they choose not to do it, then that's when I would be, laying a little more blame on the person rather than the healthcare system that's failed them. That's just my personal view. Not entirely would I blame them, but I think they have a little bit more responsibility at that point when they know what's wrong and they know how to fix it and they choose not to. Of course, that's my personal view. That's not the view of Duke Spine Institute necessarily, but we have other providers here that may see things differently, but that's the way I see it. Sonny, you have a question?
Not at the moment.
All right. And one of the reasons why the grabbers don't work, by the way, in case you're wondering, is you can't get enough force to grab it. All right. So, for example, if you've ever gone to, like Chuck E. Cheese pizza parlor, right? Or anywhere where they have games. They have this one game where you put $1 in the machine and it's got a crane. And the crane reaches down and grabs something like a toy doll or whatever. A lot of times the grabber can't grab the doll and hold it because it just falls out of its mouth. And that's because the amount of force that it closes with is very, very too little. So hold the doll, right? If you guys know what game I'm talking about? Yeah. So when you put a grabber down here and you grab this piece of tissue right there that I'm working on, it grabs it, but it can't hold it. Even though it has a cutting side, it can't cut it and hold it and pull it out. It's just not enough force because it's a long, skinny handle to go down the endoscope. So you need a beefy handle with, strong metal so it doesn't deform under that force. And there is no such thing. It doesn't exist. So there are limitations to metal surgical instruments that are more or less related to their physical ability rather than the fact we can't, we just don't want to use it. It doesn't work. It can't handle it. This is all scar tissue right here. Just thick, thick, thick wads of scar tissue in the annulus fibrosis. And it's evidence that the annulus has been under inflammation for a very long time. Look at the golden color is all dystrophic calcification. It takes years and years of inflammation to get to that level of dystrophic calcification. Okay, as they say, like the Grand Canyon, right? That was formed by water, by literally a river of water over thousands of years, wearing away the dirt to make the canyon. Okay, so that canyon can't form overnight. I can't move my fiber. I'm not able to rotate it. No, it's not. I need 5 minutes. We're going to be done in 5 minutes, doctor. Okay? 5 minutes. Just getting to the end here. And I know that because there's so much scar tissue. And the only way you get that much scar tissue in a disc is when you get close to the outer part of the annulus. Remember, the inner half of the annulus has no blood supply, so you can't have scar tissue or inflammation. But it can grow down the annular tear, like leapfrogging, basically. And that does happen. If you watch our video, you'll see that. But the point I'm trying to make, though, is that all this thick scar tissue tells me we're getting closer to the outside of the disc, to the tear. And we're almost done. We'll be in the foramen soon, the epidural space, if you will. Questions?
No.
So, none yet?
No.
So I'll be over there in a few minutes, Sonny. And today we have one case. This is the only one. We have more surgeries next week. If you want to look at our calendar, you'll see what we have next week. But basically, this is our only surgery for today, so thank you for joining us. And type your questions up. We do have the Deuk Spine app on iPhone and Android platforms, which is free to download and use. And again, it's not static. We're still developing it. But Zach's on vacation this week, and when he gets back, we'll start working on tidying it up, making it even better. We do have some new blogs going out this week, some interesting blogs that we're writing about spine surgery. Whew, look at that. Oh my, forget the 5 minutes, it may be 8 minutes. This is all scar tissue here, wow. From the tear trying to heal itself for a long time. So if I try to grab this, it simply will not grab. Plus with the grabbers, you have to have a piece to grab. That's like a smooth surface. You can never wrap the pituitary around the smooth surface and pull something out. So pituitary rongeur has to have a chunk to grab. May be able to grab that chunk, but then again, I think that chunk still is pretty firmly anchored down to the annulus, which is not going anywhere. Let's see if I can grab it with the grabber. I'll do a Boy Scouts effort here. Alright, so we got some of it. I just geometrically can't get it to where I need it to be to get all of it. But have no fear, the laser is here. Oh, Luis, guys, gals, come on, I gotta get excited about something. Huh? Alright. Well, I think our patient's going to be happy with the end result when he's healed up. I suspect because of the soft tissue pain that he has, he's going to need a few weeks to get rid of all this surgery pain that I've given him for his tissues to settle down. Now, the real question is, will fixing the disc pain, will that help him with his soft tissue pain? And that's a great question I don't have an answer for. I don't see enough people like him where they have that soft tissue pain so bad that I can actually know an answer based on my experience. It's extremely rare to see that kind of discomfort though at the beginning of surgery. So I know it's real, and I know it's really happening for him, and he's experiencing that. I just don't know how much of that soft tissue pain goes away with laser surgery. It's a great question. Someday we'll have an answer. I'd be curious to see how he's doing in a couple of days. All of our patients, typically the surgery pain goes away overnight. So we'll see if his pain goes away overnight. That'll be a pretty good first indicator. Whew! This is just incredible, the amount of scar tissue. Can see him breathing, how it moves the disc, it changes the pressure in the disc. Coughing, breathing, we call that Valsalva, and that pressure from the abdomen is transmitted to the disc and the spine. So, is he okay? All right. And the reason I'm looking down towards the tear is, if you remember, based on the x-ray, we entered the disc above the tear, and I was forced above the tear because of the facet configuration and anatomy. It was so abnormal from the arthritis in his facet joints, which we're not addressing, but we may end up having to address. We'll have to look and see how he's doing afterwards.
We have a question.
Sure.
When would a patient choose an orthopedic spine surgeon or a neurosurgeon to operate for disc herniations and stenosis?
Well, that's a great question. When would a patient choose a neurosurgeon or an orthopedic spine surgeon to treat their spinal condition? So, to meet for herniated disc or stenosis, the answer is actually today it's quite simple. Because the very best surgery for a herniated disc and stenosis is what you're watching right here, right now. And I happen to be a neurosurgeon. And I'm the only one that does it. So there are surgeons who do endoscopic surgery, but they don't do the Deuk Laser Disc Repair. And the Deuk Laser Disc Repair is a very specific type of surgery that is designed to treat the tear, the annular tear, rather than just the herniation. We treat both. And the reason why so many patients have back surgery and they still have pain is because the surgeon did not fix the annular tear. And the reason they didn't fix it is, number one, they don't have any idea the annular tear is the cause of pain, because they don't know that. It's a newer discovery. And number two, they don't have a way to treat the annular tear. All they do is a discectomy. So if you look at the surgeries they do, it's called microdiscectomy. They're taking the herniated disc out. They're not fixing the annular tear. That's why the patients who generally have microdiscectomies, they end up still having back pain because the surgeon never fixed the tear. So the lack of knowledge about the source of back pain and the lack of knowledge about how to do this procedure basically mean that there's only one surgeon right now that knows how to treat the herniated disc, the back pain, and the stenosis properly, and that's me. And I'm a neurosurgeon, so it's a bit of a strange answer, I admit it, but it is the most truthful answer I can give you. Aside from that, if you just want to go with a more traditional spine surgery that doesn't really work that well, then anytime the nerves are involved, in general, I would trust a neurosurgeon over an orthopedic. Neurosurgeons have far more training than an orthopedic surgeon does when it comes to spine conditions. And that's a generalization. It's not always true. There are some orthopedic surgeons that are better than neurosurgeons, and there are neurosurgeons that are better than orthopedic. So honestly, it really has to do more with How good your doctor is, whether they're orthopedic or neuro, is, I think, less important. You know, I've seen some orthopedic surgeons that are far better than neurosurgeons at certain issues treating in the spine. For example, pediatric scoliosis. That's scoliosis in a kid, their spine. The best pediatric scoliosis surgeons are orthopedic surgeons, period. And that's who I refer my kid patients to when they need a big, long deformity correction. All right? The best spine surgeons for piriformis syndrome, okay, which is a torn muscle in the buttock causing pain. That's an orthopedic surgeon. So when it comes to certain conditions like piriformis syndrome, pediatric long segment deformities, like idiopathic scoliosis treatment, sacroiliac joint fusion, tumors of the spine and pelvis, I think orthopedics are generally better. But for decompressions and stabilizations, I think neurosurgeons in general are better. So your question was more about stenosis and disc problems. I would have to go with the neurosurgeons if I had to pick one. But remember, not all neurosurgeons are trained and they're not all equal. And if you think they are, you'll be really badly disappointed. There are a lot of really bad neurosurgeons, spine surgeons. A lot. At least 50% of them, maybe more, maybe closer to 80, 90%. But still, there are more of them that are better than orthopedic spine surgeons. Orthopedic spine surgeons, generally they do orthopedics for 5 years, doing knees and hips and shoulders, nothing to do with spine at all. And then they go do a fellowship for a year. And they do a fellowship in spine for 1 year. So basically they're getting 1 year of training. Neurosurgeons do 7 years of training, and at all 7 years we do spine. So we're getting 7 years of spine training and operating and managing, whereas the orthos are doing 1. So it's not just about the title ortho neuro, it's also about the training. And it's about the mindset, I think. The mindset of your doctor is very important. As long as they have a really good mindset, they want to do really good with their field, they want to be the best at what they do, they go out and learn all the time, study new techniques, new technology, make sure it's good, it works before they apply it. I think that's the sign of a good doctor. Low complication rates means they take pride in their work and that they take control of the situation. You know, complications are, in my opinion, with spine are almost exclusive. They're almost always avoidable. Depends on the specific complication, but it has a lot to do with your team, the anesthesiologist, the nurses, the doctor. You know, complications aren't just a result of one person. They're usually a whole team. Alrighty, we're done. The case I thought we would never finish, but we did it, and I'm happy. And we'll get this patient recovered and back home. So very difficult to get to where we needed to go, but when we finally did, I feel like we got everything done well. So I'm optimistic for this patient to have a really good outcome. Again, yeah, we need to get this out before he wakes up, otherwise he'll freak out. So we'll put pressure on the muscle. I don't want to be any bleeding in the muscle because that's going to make the pain even worse. You can break things down. I'll hold it for a minute. If blood, okay, so there's a channel like a tube, okay, that we created. So you see this, honey?
Yes, sir.
We call this the McDonald's shake straw. So this went in. This was like the final thing I put in. It's called a tubular retractor. Tubular for the obvious reasons, it's shaped like a tube. Retractor because it holds the tissues around it at bay. And what it's retracting is the skin, the fat, the fascia, the muscle, and that's pretty much it as it goes down into the disc, okay? So you guys see this? I'm working down here inside the disc, but I'm putting all my instruments through here. Does that make sense? See that, Sonny?
Yes, sir.
All right. So when I take this out, nothing down in there is damaged except for the skin, which has a cut. Remember, there's 2 incisions. Okay, two Band-Aids. So there's no damage done at all except for the skin. However, there's we spread the tissues apart. Now, if there's some bleeding along the wall of what we spread apart, it could go up or it could go into the muscle. I don't want it going into the muscle. If it goes inside the muscle, it's called intramuscular. And the real big issue there is number one, we don't want to have a little bit of intramuscular blood because what happens is that breaks down, and it takes about 2 to 3 weeks to break down, and your body dissolves it, and that's fine. But during that breakdown process, what happens is it releases hemosiderin because red blood cells break down into hemosiderin, and that hemosiderin irritates the muscles and causes muscle spasms and pain as a result. So you could go from having just pain for a few hours, which typically happens with a surgery in the muscle, to having pain for weeks. And I don't want that situation, especially not in this patient if I can avoid it. EBL 10 mil, no complications. I'm sorry? Yeah, patient asleep. And this was a right side? L45, 5S1, thank you. So I'm trying to avoid an intramuscular bruise or clot because I want to avoid this patient having inflammation inside his muscles after surgery as a result of the hemosiderin. Great job. All right, let me come and answer questions. So type your questions up and I'll come answer them.
If you have the means to do this, you should do it because it's life changing. Thank you.
You're welcome. I'll see you out there on the go-kart track. You want to say to the rest of the world before we wrap this interview up?
If you're thinking about it, come see Dr. Deuk. I've been telling everybody, come see Dr. Deuk. You changed my life.
I'm so happy for you. Take care.
This guy's the man. Come see him.
Oh, thank you very much. Take care.
Anything else you want to say to the audience before you get out of here and go home?
It's a good place to come and get answers.
Absolutely.
Anything you want to say?
He's worked on both of us, and we can't say enough to thank him enough for his expertise and willingness to do things that other doctors would not do, wouldn't take even the risk at doing. He's able to do that is beyond our comprehension, and we are very grateful and thankful for Dr. Deuk.
Duke Spine Institute is grateful for both of you, so thank you.
Thank you.
You're welcome.
If you have the means to do this, you should do it, because it's life-changing. Thank you.
You're welcome. I'll see you out there on the go-kart track.
You want to say to the rest of the world before we wrap this interview up?
If you're thinking about it, come see Dr. Deuk. I've been telling everybody, come see Dr. Deuk. You changed my life.
I'm so happy for you. Take care.
We went into the herniation right there, like that. Okay, you all see that? Right there? Good. Okay. Most spine surgeons, when they do surgery, they come straight down, they get into all the bone, they got to remove it. It's called laminectomy, foramenotomy, but we're coming through the foramen from the side, endoscopically. So basically, we got in there and I cleaned out the tear in the back of the disc. This is the front of the disc, this is the back of the disc, this is the top and bottom like that where my hands are. So I basically got into the disc like this, went into the tear, and I just zapped away that tear using the laser as I pulled the tube back, and I just cleaned this tear up and got rid of all the jelly. So it went, eventually when I got in it went really well. The trouble was getting in, and if you look at this model here, normally it's kind of easy to get into the herniation from the foramen over here, but this patient was twisted away like that, so I was bumping on the facet and I was being deflected to the side, and that was because the facet was enlarged on that side, the side that I was on. So normally it's easy to get in, but when the patient's spine is twisted and when they're moving around, you know, because they're hurting, it's a lot harder to get in. So eventually we got the patient comfortable. I got into the disc, I fixed them, and I feel like this patient will do quite well. What I'm concerned about is not the discs themselves, but this patient has a lot of pain in their skin and just below the skin and in the fat. He doesn't have much fat, but he's got fascia and fat down there. And just passing through it with the needle created a lot of discomfort for him. So I'm hoping all that goes away in time, but he does have, he was using ice packs for a long time, and he has this abnormal skin because of the ice packs. It looks like the skin's had some changes in coloration, and it didn't feel normal either. It's not normal to have that much pain going in with a needle. The needle's pretty small and skinny, so I have a little bit of concern about his soft tissues after surgery, but we'll see. Time will tell. I think eventually he's going to do fantastic, but I think he's going to have a longer recovery than most patients. All right, so what is our first question from our audience?
All right, so the first question we have is, what is causing pain when I get up to do something that requires me to put ice packs on area? Ice packs are my savior when pain meds aren't working. I'm fine laying down, only when I stand up.
So one of our viewers from
YouTube.
is asking, hey, I get back pain when I get up. I'm fine when I'm laying down. Why is that? And the answer is, so when you're laying down like this, these are your discs right here, these cushions. When you're laying down, you're putting pressure on your discs. They're like literally collapsing. Think about your whole upper body, maybe 100 pounds worth of weight. When you get out of bed and you're up, sitting or standing, walking, you got all your arm weight, your head weight, your neck, your lungs, and your heart. Everything is going right through your spine. So there's nothing else in your body that holds you up besides your lower back spine, the spine in your lower back, the lumbar spine. So think about that. All that extra weight going through there, it actually puts pressure on the disc, and it can squeeze the jelly out through the tear a little more and cause more pain and inflammation. So basically you got all these little nerves around that tear. And Sonny, is there any way to play that YouTube video for our audience right now?
The animation? Yeah. Give me a second.
So I got the master mixer right here. And Sonny is gonna bring up the brand new YouTube animation, and it's gonna answer your questions, because when you see what happens when you put pressure on the jelly, you'll see that pressure pushes right through the tear in the back of the disc, causing pain. So that's why you're getting your back pain. So Sonny is gonna switch us over right now to the video so you can see it. How much time do you need?
2 seconds here.
We're going to try to do this for the first time.
YouTube Chrome, okay. They should see it now.
Can they hear my audio or not?
They should be able to hear your audio.
Well, hopefully you can, but you can see the annulus is that light blue strip. Now there's a tear. That's traumatic. You've already got that. And then every time you get up, you're like pushing the blue stuff, that dark blue stuff, into the tear. And it's creating, over time, inflammation. So watch what happens to the tear. It's going to turn pink. That pink is kind of like a zit or a splinter in your finger, and then you start pushing on it with your other finger. It creates pain signals in that inflamed tissue. All right? So that's why you're getting your pain every time you get up. You're putting pressure on those nerves, those yellow nerves that are located inside that inflamed area of your disc. Okay? And those pain signals, of course, travel from your herniated disc in your back all the way up to your brain, and they go to a specific part of your brain called the primary somatosensory cortex, which is important because pain signals go to other areas of the brain, they don't feel painful. But when they go here to the primary somatosensory cortex, they hurt like heck, and they're very localized. So that's why you're getting your back pain. Okay, that video is available for everyone to watch. But that's the answer. So the fix is going to be the Deuk Laser Disc Repair surgery we just did. Any other questions from our audience?
If the patient develops foot drop, can that be reversed?
So the next question is, if the patient gets a foot drop, can that be
On
reversed?
YouTube.
So any way to bring that video back up again?
Yeah.
I mean, so this is how I see these sessions in the future going. Go to the middle, or go to, yeah, a little further, and yeah, right there, and get ready to pause now. Okay, so you guys see the big blue lump right there, the dark blue, royal blue lump. And look at that thing that says motor nerve, motor nerve. Those are the nerve fibers that go to your drop foot. So if that blue thing irritates the motor nerve enough from inflammation or pushes on that motor nerve, if it gets big enough, then you're going to get a drop foot. So to answer the question, if I go in there with the laser and zap that away, will you be able to have strength again? The answer is 50% of the time, patients wake up from surgery and their drop foot's gone. Literally gone right away. The other 50% take about 6 months for it to come back. So it just depends on the patient and how big the herniation is and how much damage it's caused to the motor nerve there. Okay? And I can't really answer it the same for everybody because it's really individual, up to the individual patient. My advice to you, if you have a drop foot from a pinched nerve at L45 or L5S1, get it fixed ASAP, immediately, because waiting is not good.
That's it.
All right, well, I hope you enjoyed surgery today, and I hope the video was helpful. We spent a lot of hours creating it, and we've got more that are coming out soon that are going to be released.